imaging.
Yeah, solo.
Super nice. No, I always remember that would be all about people, because like people pins, when you go from the predominant back to the root, say they go to dominant.
MEG meets country.
Like, you go the other way. Yeah.
Just think of like pedal, like pedal, it's going around.
Nurse.
Yes.
Jen said, bugle like a fugitive running away.
It's just the opposite.
What's wrong with dominance? You know?
Yeah.
Like, or simple.
I don't think I've ever heard somebody make it like a lot more complicated. Like that you have to have the pre-knowledge. It doesn't count. So it's not helpful. You can be rooted.
People here consider cool, man. Very cool.
So next comp, we're gonna be diving into imaging the abdominal vessels branching off the aorta that are supplying blood flow to our mesenteric. So these are referred to as the Splanchnic, 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 mesenteric arteries. So we're gonna talk about celiac artery, SMA, IMA. And then with celiac, try and get some of those branches. So splenic arteries, common hepatic artery.
Not everyone.
You see that?
The celiac active branches.
We'll talk about some pathologies that are involved with these vessels, namely mesenteric ischemia. So that's one of the main conditions that they might ask you to try and rule out. We'll talk about mesenteric ischemia, what's involved, the characteristics of it. So we know that when we're imaging the abdominal aorta, the resistive indice in the aorta changes, as we work our way further distal. So above the level of the renal arteries, it's lower resistance because we do have blood flow going to the kidneys via the renal arteries, blood flow going out to the liver and spleen, via the celiac artery. But then once we get below, the level of those renal arteries, the resistance changes. We need to understand what's normal flow patterns with those branch vessels. So celiac, we'll see in a moment. Resistive indice doesn't change whether they're postprandial or preprandial, but the vessels SMA and IMA will have changes in their Doppler characteristics. So knowing what normal is, then knowing what would happen, if the patient's fasting, will help us to determine what happens after they eat, and preprandial will help us determine, if there is potential disease present. So definition. So these are the vessels that supply blood flow to the bowel. Celiac artery, SMA, IMA. Within these vessels, we're looking for stenosis and or occlusion. The occlusion could be acute. So maybe the patient has, cardiac issues and a thrombus gets ejected, emboli gets ejected from the heart. It can get lodged, in these vessels, in these arteries. So they can have an acute occlusion, via thrombosis, in one of these vessels that would lead to a sudden onset of symptoms. Or it could be the slow process of atherosclerosis and the vessels becoming more calcified, more stenotic, buildup of those atherosclerotic plaques leading to chronic ischemia. So again, the manifestation, the patient symptoms will be a little bit different, acute versus chronic. We'll get into that. And it's also too important to know that, these vessels, they are interconnected. So the body has wonderful, it's got these beautiful collateral pathways where blood flow can get around, either stenosis, major stenosis, or even occlusion of these major branch vessels, and they're interconnected, and blood flow could still get to your digestive tract, still get to your pancreas, still get to your stomach via some of these collateral pathways. So the three main principal pathways are this, what is referred to as this pancreaduodenal arcade, or via the gastroduodenal artery. So this links the celiac artery with the SMA. Just gonna have to raise my voice a little bit, drown out the Dremel. So pancreaduodenal arcade. So I kind of, those of you in DMS, we know that when we're imaging the pancreas, We're right below the level of the celiac access. We know gastroduodenal arteries are branched off of, our, common hepatic. Or actually, it's technically proper hepatic, but, it's right there at the branch off, the hepatic artery. Um. So that branch dives down, and then there's small collaterals that will continue and branch off and then connect via collaterals off of the SMA. So we get, again, kind of like a looping or connection between celiac artery and SMA. So we can get blood flow, so cases where the celiac artery, and one more retrograde back up via the SMA to supply, gastroduodenal artery territories, stomach, pancreas, and liver. Further down, a little more distally now, we have this arc of myelin. So this links the SMA and IMA, and then the marginal artery of Drummond also links SMA and IMA. Those are a few other collateral pathways further down. This is just kind of like an angio, showing some of the collateral pathways and the tributaries and how they're connected. So P in this curvature, see, we have IMA, anterogram, IMA, curved arrow. And the positions of that arc of myelin, the marginal artery of Drummond, the straight arrow. I think I have a better diagram. I know for boards, they expect you to recognize the pancreaduodenal arcade or collateral pathways that connect celiac and SMA. And then the other two, the arc of Ryelin, and the marginal artery of Drummond are the ones that connect SMA and IMA. So if you can kind of just differentiate those three and recognize, which connects to what, you'll be in good shape. These collateral pathways aren't things that we actually image on ultrasound, so you're not going to be going in there trying to look for any of this. Yeah, and I like to always kind of, for this lecture, I always talk about my grandmother. She's 92. Like, she's always been complaining of digestion problems for like a long time. It's been many, many years, and always like acid reflux. She can't digest her food. She's always having acid reflux, digestional problems, like constipation issues, like all this GI stuff. And it happened that they were doing I guess a CT to just kind of look at, all that stuff, the organs and everything. And the radiologist happened to notice that either SMA was occluded on her thing, like no one ever really picked it up on it. And they looked into it, and SMA was completely occluded. IMA they didn't even see on the CT, so they assumed that was occluded as well. And her celiac artery was something like 90% occluded. But there's all your digestive problems right there. None of your digestive tract, stomach, nothing's getting blood supply. So she went in and she was almost 90 at the time. And they went in here at Christiana, they tried to stent it open. They got the SMA to about 60% open. I'm not SMA, celiac artery about 60% open. But that's really the only thing that's, supplying blood flow to everywhere. So that celiac, via that pancreaduodenal arcade was getting blood flow into the SMA territories. And then those SMA territories were linked to the IMA territories, via those collateral pathways. So basically celiac was supplying everything, it's what's supporting her right now. And every time she complained, or not doesn't complain, but mentions all these digestive problems still, and they're giving her Tums and Pepsis and not gonna do anything, unfortunately, Right, so one condition that can exist that you guys need to familiarize yourself with is something called median arcuate ligament syndrome, or MALS. Your name? Who had it? Go from your school? You've had, two students previously at it. Let's see if any of you have it.
She had a bunch of other things. She also had Nutcracker.
Yeah,
She had a lot of things that were wrong and they never knew, like, it took a long time to figure out, like, everything else.
so. Easier name to remember for me is celiac band syndrome. Because in the name, it tells you which artery is being compressed, which one's involved, celiac band syndrome. So this is obstruction of the celiac artery, sometimes the SMA, but primarily the celiac artery by this median arcuate ligament, producing intermittent mesenteric ischemia. So this median arcuate ligament is a ligament that attaches to the bottom of your diaphragm and then inserts below the celiac artery. And then with respiration, every time you breathe, when your diaphragm's going up and down, that ligament is becoming taut and tight and compressing the artery. And then when you inhale and your diaphragm goes down, it's loose. So you're getting this intermittent compression of that celiac artery. It's compressing and causing a stenotic lesion. You know, when you exhale, it goes up, compresses the artery, makes it stenotic. And then when you take a deep breath in, it loosens. So you can imagine your whole life, you're just kind of constantly doing that every time you take a breath in. It's positional as well. So sometimes, you know, the patient sits up, it could relax. When they lie back, it tightens again. So it can be positional as well. Symptoms can be non-specific, but if they do have some symptoms, you know, they usually complain of some sort of cramping, gastric pain, maybe some nausea, vomiting, diarrhea. Because again, so that artery is bringing blood flow, you know, to your stomach, your duodenum. There could be a presence of abdominal bruit that's related, you know, to respiration. So again, causing that stenotic lesion, you might be able to hear it when they're breathing. This was just kind of a underview of that. Looking at the diaphragm from underneath, I'm just getting an idea of the layout of the diaphragm, some of the hiatuses for the esophagus, the IVC, aorta. So here we can see MAL. So this is that median arcuate ligament there. So characteristics of this syndrome, there's a marked reduction or disappearance of the celiac obstruction with deep inspiration and return of a stenotic appearance with expiration. So again, deep breath in, diaphragm's going down, that ligament's becoming loose. So that stenotic waveform or the aliasing, you know, will go away. The velocities will drop down to a normal level and then return with expiration when they breathe out. So again, sonographers should just be aware of this condition. They can surgically lyse that ligament to try and relieve it, you know, if the symptoms are severe and it's causing, you know, major issues to that patient. On ultrasound, that celiac artery takes this classic, what's called a fishhook appearance. So if you're scanning celiac artery, you see kind of do this little like hook rest turn, you know, and then you get some fast turbulent flow, some aliasing in there. You should take some careful consideration, some extra images. Have the patient, you know, take a big deep breath in. So when they breathe in, this thing should straighten out. I've definitely seen it just kind of go from fishhook and relax and straighten out. And then you got nice normal velocities, the measurements drop. So this was kind of showing, you know, you got the fishhook here, they're trying to Doppler, they're getting velocities of almost over 300 centimeters per second. And then with deep inspiration, you're dropping down to 120 now. So again, it could also be positional. So this is kind of picking on the point that like With the patient supine, they didn't get the same, results, or it wasn't as significant as when the patient was, scanned, erect versus supine. Or when they were supine, we didn't get, the velocity were still elevated when they were supine. But when we sat them erect, we were able to see that, change in the respiratory variation with it. Again, it could be positional. Another case, median arcuate ligament syndrome. Looking for that nice, fish hook appearance. Celiac with respiration was over 400. And 500. And then when they had the patient sit up and stand in the run, the velocities dropped down. I thought he was almost done. He was like on that last window. Doing the one all the way down. He got all the way to the corner. I was like, that's
Super high.
ultra high, I know. All right, arterial characteristics. So we're gonna go through each one individually, talking about the arterial characteristics, what the Doppler waveform should look like in the normal patient. So we know that the celiac artery is the most solid or most superior abdominal branch of the aorta. We know it comes off the anterior surface of the aorta. It bifurcates or actually trifurcates into the common hepatic, splenic artery, and left gastric artery. The organs that celiac artery supplies, goes out to the liver via the common hepatic. Branches off the common hepatic also supply the pancreas via the gastroduodenal artery. We also have the spleen via the splenic artery, stomach, left gastric, duodenum as well, and a small portion of the bowel, so the duodenum as well. In transverse, we best visualize the celiac artery coming anteriorly, facing kind of right at you, and then the branches into your common hepatic and celiac, creating a T or seagull sign. It should always be a low resistant waveform, so regardless of whether they're fasting, the resistance does not change, so it should be our nice typical low resistance arterial waveform, basic. The velocities can increase postprandially because of digestion. Usually it's not that significant, but you can get an increase. Most important number to remember here is our 200 centimeters per second. That's the one that you have to kind of star and highlight and determine whether or not there's been a. The velocity should be less than 200 centimeters per second for the celiac artery. Now, over 200, we're worried now about stenosis. With celiac artery stenosis, we look for a localized area of high velocities. Put your color on, look for post-stenotic turbulence. Look for post-stenotic turbulence in your Doppler waveform. If we go distal to the celiac artery, so working our way further distal and into our branch vessels, we would look for a targus parvus, a blunting of that downstream waveform. And we look at the celiac artery velocity criteria table. So again, greater than 200 centimeters per second is considered stenotic. So normal should be less than 200. On ultrasound, when we're in transverse, we have our aorta now in transverse. So we're technically kind of just superior to where we are, where we see the pancreas. Celiac artery, or the branches of celiac artery, make the superior border of the pancreas. So when we were scanning here in lab with getting the pancreas and the portal confluence, just kind of tilt up a little bit, and you should be able to image that celiac artery coming in with this seagull. So again, the branch that goes out towards the patient right is the common hepatic. The branch that goes out toward the patient left is our splenic artery. Again, not everyone is the same. So, here's one that's a little more tortuous, and then you got the splenic artery, and you got a nice big loop, hepatic artery diving down. Nice seagull sign there. The trick with this is because we are measuring velocities is Doppler angle. That's the hardest part about this, making sure that you're lined up properly, you have a nice Doppler angle. So when we get in lab and we start imaging, our celiac artery, so this might be a good example where we can just utilize zero angle because we might just be lined up, nice and perfect. Whereas this one, we would have to put our Doppler angle and try and align it. So don't be afraid to again adjust that Doppler angle. Again, as long as we're under 60 degrees, we're okay, we're good. And you're going to measure peak systolic and end diastolic with these, measuring those RIs. So normally, it should be around 100 centimeters per second. Again, if peak systolic velocity exceeds 200 centimeters per second, it equates to a greater than 70% stenosis. You can also potentially look at that end diastolic velocity as well, but really boards and the questions that I've seen have only focused really on that peak systolic velocity. So any review books that we've been doing, for students prepping for boards, they hone in on that 200 centimeters per second. So again, commit that one to memory. Greater than 200 is considered hemodynamically significant stenosis. I don't know what's going on there in that picture. That's nuts. They're trying to show a color brewery, a stenotic lesion, just like, and all the aliasing and the vibration of that brewery, create an artifact. We can get better pictures than that. So now this is a sagittal aorta, where we can see that artery coming up. So that's a little bit of a visual to it, the low coverage to it with color on it, everything representing probably some elevated velocity, some turbulent flow. So then you're trying to get a good Doppler angle. So you could try and Doppler it in transverse, get that seagull. You could try and sagittal if that line's a little better, if you get a better picture. So there's really no wrong way to really try to use it celiac because it is coming off the anterior aorta. So we can see it in both sagittal and transverse. When you want to see the branch vessels, that's typically done here in transverse. Yeah, now it's definitely stenotic, 456 centimeters per second. Elevated stenosis. I don't want to say the good thing, but the thing with a lot of these abdominal stenoses with these mesenteric vessels and the renal arteries, the stenotic lesion is going to be at that proximal segment. So where the atherosclerotic plaques build up. Same with carotids, we know it's in the bifurcation, the bulge and bifurcation where the artery splits. So same thing here. You got splitting of that of the vessel, we lose that nice laminar flow. The stenotic lesions like to develop right in that proximal segment. And our celiac artery sag. So right near that origin, velocity is, off the charts there. We moved a little more distal, and now we're getting the Tartarus parvis waveform there, so that delayed upstroke. Another example, celiac artery stenosis from the VAS lab. Meets our velocity criteria, over 200 centimeters per second. So there are some anatomical variants, that do exist with the celiac artery. Oh my Rochelle. You guys know Rochelle CBS? Have you met Rochelle? Yeah. Met her briefly?
I did. She's the one that gave me her books.
Okay. we were doing scanning her lab, trying to look at hepatic artery. I want to say her hepatic artery was off the SMA. It was that one. It was very interesting. Yeah, so we were trying to find, yeah, it was, because we were trying to find the other branch of the seagull, and it was like one armed seagull, one winged seagull, and like, it was like, but like we see her hepatic artery with like going to her liver, like going there, we're like, where's this thing going? We're like trying to track it, and like we were able to connect it back to the SMA. Yeah. Yeah, dual hepatic artery supply there. The anatomical variants again just do exist. So not everyone's gonna have the same, just recognize that. That's when things become tricky. So these vessels could become aneurysmal. So this is just showing celiac artery aneurysm. The hepatic artery. So with the hepatic artery, we can try and locate it, near the porta hepatis of the liver. It's gonna be anterior or in front of your main portal vein. If you have your bile duct there, kind of give yourself kind of an orientation. You can image the bile duct. So again, these represent that portal triad, so they course through the liver, together. So when you find the hepatic artery, you can try and elongate it, open it up. So nice hepatic artery anatomy. So beautiful aorta, celiac artery, your common hepatic artery. So here was just showing closer to the liver in the proper hepatic with the common bile duct and your portal vein. Depending on, how detailed your lab gets, they might just be content with you doing a proper hepatic artery, near the porta hepatis where it enters into the liver. They might not require you to try and actually visualize that bifurcation into right left hepatic arteries. Or, you could try and image it in and see it splitting to left lobe and the right lobe. So it's gonna look very similar to the split that you would see when you're doing your main portal vein. Just a little more proximal, near the porta hepatis. Splenic artery. So splenic artery is the largest of the three celiac branches. The important term to memorize or just get into your brain when you're thinking about splenic artery is the word tortuous. So every time you see the splenic artery described in literature or in, test questions or prep questions, and they mention, abdominal vessel being tortuous or a tortuous abdominal vessel, it's 9 times out of 10, they're talking about the splenic artery. So the splenic artery gives rise to the pancreas, some of the pancreatic branches. So it courses along the superior border of that pancreas, and there are little branches that come down to supply blood flow to the pancreas itself. There's the short gastric branches, the left gastroepicolic branches. And then it terminates at the splenic hilum. So it runs out to the spleen, terminates at the splenic hilum where it enters into the spleen. So this one again also should be nice, low resistant flow pattern. Nice monophasic waveform with diastolic flow. So this was demonstrating spleen, sagittal. Got the vessels coming in there at the splenic hilum. All right, so what's the velocity criteria for celiac artery? 200, yes. So 200 for celiac. All right. So SMA now. So now we're moving down a little bit more inferior, get into the SMA. It also arises off the anterior surface of the aorta. It's parallel and lies to the left of the superior mesenteric vein. So if you get any, you know, anatomy, relational anatomy questions. The nice thing about our body is if you can remember the orientation of aorta and IVC, aorta is to the left of the IVC, these guys are the same. The body likes to keep things nice and symmetric. So the artery is to the left of the vein, its corresponding vein. The pathways are the pathways, the areas that are supplied by the SMA include basically the whole right side, a patient's right side of their digestive tract. So the ascending colon, transverse colon, the small intestines that exist there. So the jejunum, ileum, cecum, ascending colon, proximal, or 2/3 of the proximal transverse colon, portion of the duodenum, pancreatic head. So basically all the right kind of like midline or a little bit past midline is all the territory for the SMA. You know, it's very just, we're able to identify it because of that distinctive triangle mantle of fat surrounds the SMA. So in transverse, it creates that, you know, bullseye or target sign or donut sign. The pancreas and splenic vein lie anterior to it. Or it lies anterior to the pancreas and the splenic vein. Yeah, pancreas is inferior to it. Oh no, yeah.
It's pancreas.
No, it is
or
anterior. It is anterior, okay. Splenic vein is posterior. Left renal vein, so that's our transverse picture, is posterior behind the SMA, but anterior to the aorta. So this is like in that classic picture that we see for our transverse pancreas. So left renal vein posterior to SMA. We got, sorry, aorta, IVC, left renal vein, that's a 14 proof. That probably nutcracker syndrome based off how dilated that splenic vein, renal vein is there. When we do our Doppler interrogation of it, we're gonna do our Doppler in sagittal though. So sagittal, we get nice pictures of the SMA as it branches off. So it branches off anterior and kind of just, you know, parallels the aorta as it runs inferiorly. We're gonna want to get nice, you know, 2D colored pictures for the origin or the proximal segment of it, and then see how far down we can follow that SMA and try to get, you know, more mid or distal segment of it. So SMA and IMA are the two vessels that are unique because their resistive indices will alter greatly depending on whether or not the patient is NPO or they've just eaten. So when the patient is fasting, we expect to see a high resistant. So this is even triphasic, but it's a higher resistant waveform when the patient is fasting. And if they're postprandial, if they've eaten, that waveform characteristics change to a low resistant monophasic waveform. So when we get into the actual exam, it's important, you know, for us to really be 100% sure that that patient truly is fasting. Because if they say they're fasting and we Doppler and it's a low resistant waveform, that could indicate that there's disease or they're suffering from mesenteric ischemia. Because the intestine is starving for blood, it's going to lower its resistance to try and get blood flow into it because it's ischemic, it's starving for blood, it needs the blood. So if they're fasting and the resistance is low, that's not a good sign. So either they're lying to you, they had something for breakfast, they had a cup of coffee with a ton of cream and sugar in it, you know, they're fibbing, or they could have mesenteric ischemia. So we really have to be 100% certain that that patient is fasting, you know, for that exam.
for like 6 hours, 6 to 8 hours.
at least, yeah. I mean, ideally overnight would be best.
Okay.
Uh, So velocity range. The one I care about, again, peak systolic velocity. So now it bumps up a little bit. We got 275 is our magic number. So you're gonna love these numbers because they're nice and uniform. 200, 275. What do you think IMA is?
350.
200.
Yeah.
200, 275, 200. So you can make a little velocity sandwich. 200 and you get 275 in the middle. And here we see a nice fasting, SMA. Again, with any stenosis, when we put our color on, we look for narrowing, turbulence, blood flow, the aliasing within that. Here they measure peak systolic velocity 283. So again, that meets our criteria of being stenotic. Elevated velocities a little further down. They got turbulent blood flow represented by the turbulence below the baseline there. And 299, almost 300. The post-stenotic turbulence a little further distal. SMA syndrome, or sometimes referred to as Wilkie syndrome. So this is a very rare occurrence, and it results in compression of the duodenum by the aorta and SMA. So in these patients, they're lacking that triangle mantle of fat that makes the SMA distinguishable. And because that's absent, the SMA then it's not like supported and propped out, so it doesn't have that nice kind of like little arc to it that we see when it's branching off. And it squishes the duodenum and compresses the duodenum between the aorta and SMA there. So if you're crushing your proximal part of your small intestine, that's going to lead to obviously digestional problems and issues. Food's not going to pass easily through there. So symptoms include nausea, vomiting, stabbing, abdominal pain, advanced malnutrition, could lead to gastrointestinal bleeding. And actually has a very high mortality rate if not, corrected. So chances are this is a pediatric thing, that you're going to encounter.
Yeah.
You're not going to get very far into your life if your food's not passing.
It's weird that the SMA has enough, like, I don't know, pressure or whatever to compress the duodenum.
Yeah.
I wouldn't have thought that.
Maybe it's like, what else is? Maybe it's not like the SMA itself, the weight of the SMA. It's more like
No, everything else. is
everything
like,
else, just
uh,
like that's there to keep it like
from compressing.
from being compressed. It's just like you're, I don't know. So here's the intestine, like you can see it being like crushed, on that CT. That's a little picture. So celiac artery and SMA. So again, just get comfortable being able to, recognize an ultrasound celiac SMA. We know celiac is more superior, more cephalic, SMA. Just below that, SMA comes off and kind of, parallels the aorta. You got the echogenic mantle of fat that surrounds it. So even on, on sagittal view, you can still see the echogenic, surrounding that artery there. Right, IMA. So this one now provides, I think, the patient's left side of their body, the parts of the digestive tract on the left side now, all the way down to the rectum. So location, it's midway between the renal arteries and the aortic bifurcation. Kind of like you know, if renal arteries are mid, and bifurcation is the end of the aorta is kind of like mid distal. This also arises off the anterior, but slightly to the patient's left. So it's the left anterolateral aspect of the aorta. Again, it's supplying blood flow more to the left side of the patient's body. This, similar to SMA, will change resistive indices based off of the patient's preprandial or postprandial, whether they're fasting or they've just eaten. Like I said, we discussed, there's connections between SMA and IMA through that arc of Ryland or the marginal artery of Drummond. And serves as a major collateral during SMA or celiac artery stenosis. So when we're imaging or trying to do this in lab, we're going to be scanning down the abdominal aorta, getting to that area, you know, a little bit above the umbilicus, and start looking for a small circle or small vessel, you know, just to the left and anterior of the aorta. So we're going to be looking kind of in this area to the left of the patient left of the aorta and just anterior. And once we locate it, we're going to kind of just keep coming superior, and eventually that's going to connect into the abdominal aorta. So we're going to look for where it inserts into the abdominal aorta to image the origin of it. So this vessel, you really don't see a large segment of it unless, you know, the patient's super duper thin and they're really clear, a nice scan. But you could try and get where it connects and get some origin and get the origin, because again, that's where stenotic lesions are going to be. That's where, you know, the vast majority of stenosis, if they're going to happen, will be right at that origin of the vessel. We'll practice. It's really easy. You find the origin, just kind of a little quarter turn, and it opens up nicely. So a nice fasting waveform, again, should be high resistant. So this was with some contrast. Now, again, you can see that IMA as it comes off the aorta there. So kind of the left anterolateral aspect of the aorta.
Why does it look like?
Interesting.
What does it look like?
Dipping down, I guess, to the.
Going down, yeah. I mean, deep. Oh, they
Because this is,
administer, this is with contrast agent. Yeah, so this is with, they, in order to visualize it, no, they put contrast into the patient. So, yeah, so they administer contrast. So these are little micro bubbles that they,
Is it like a little bit above the split?
When they turn on the color.
a little bit above.
The split, like between, before it splits into the.
Yes, it's a little bit above it. So,
Okay.
I mean,
Kind of,
renal arteries maybe like here,
and then
come down a little further, and then
Okay.
belly button's there.
I guess it'll be so gassy on most, but I don't know.
That's why I was so curious.
Kind of nervous for mine. I bet it's gonna be.
I can't look hard today. That one, she was just a wonder.
And normal high resistant Doppler waveform when they're fasting. Alright, so velocities again, 200, that's our magic number. So 200, 275, 200. 200, 275, 200. So this was showing again, IMA stenosis. Got the aliasing representing the turbulent flow. Nice picture. Coming off right there. Not a lesion. Velocity is 383, so that's definitely stenotic, elevated. Color, then you got that turbulent aliasing in there near the origin of it. Try Doppler, getting a good Doppler angle on it. Almost 400 centimeters per second. This was showing that just a patient with a cardiac arrhythmia now. They had alternating velocities that range from, you know, within that stenotic range to within that normal range. So here they were, exceeding 200. Here they're kind of right around 200, and then one below. So they took the one in the middle. But there's no secondary signs of stenosis identified. Cardiac arrhythmias again can alter and vary, your waveforms. All right. So mesenteric ischemia. So this is again one of the things that you might be called upon to try and rule out. I'll be honest, as a sonographer, try and get out of this if you can. I would always be late night working, someone in the yard, try and get cute, rule out mesenteric ischemia, someone coming into the yard, I'm like, oh.
I didn't see that Twitter.
No, I would go to the radiologist right away and be like, is ultrasound really the best test for this? Because we're gonna see in a moment, like, if you don't see all the vessels, you can't make that definitive diagnosis. So in order to make that diagnosis of mesenteric ischemia, 2 out of the 3 have to be stenotic. If you only see 2 of them, and you don't see that third one, and one of them is stenotic, one is good, you don't know about that third one, you can't make that diagnosis. You don't see 2 of them, you're not seeing them.
But if the 2 that you do see are both
Or
stenotic,
stenotic,
can you?
The diagnosis.
I get, yes, you could, if the 2 of them are. Usually I want to say when mesenteric ischemia, it's those 2 that are stenotic, usually SMA or celiac is usually okay. It's one of the last ones to go. It's usually the SMA, IMA that are the real culprits. But anyway, the other thing to also consider is, are we talking acute or chronic mesenteric ischemia? Acute mesenteric ischemia, there's no time to waste on an ultrasound because the process is, the patient has to be truly NPO, significant amount of time, at least 6 to 8 hours. Ideally, it's 8 to 12 hours. So you want an NPO. Do the scan, get your measurements. They come back and then you scan them again postparentally to look for changes, to see if there's, does it go from high resistance to low resistance? What are the velocities after they eat? So there's a whole process to this study. So again, if it's an acute thing and all of a sudden that vessel's occluded by a thrombus or embolus, they don't want to waste time. They're going to go right to CT. So again, you can ask the doctor, all right, is this acute that you're worried about or chronic mesenteric ischemia? If it's acute, nah, you don't want me. You want call the radiologist or, we need to order a different test or get the radiologist involved. Chronic, that's something, we can maybe deal with. So we're going to go over diagnostic criteria, significance, results. So there are 4 types of vascular compromise when we're talking about mesenteric ischemia. So acute arterial occlusive disease. So again, sudden onset of these symptoms. This was a normal healthy patient. They never were having any sort of issues with their digestion. All of a sudden they're having this sharp acute abdominal pain. We'll see in a moment some of their symptoms are very different. With the acute, they evacuate their bowels all of a sudden, they don't have control. So it's a bad situation. But this is caused again by embolus, so some sort of arterial thrombus embolizing and getting caught in these vessels. Potentially could also be caused by external compression of those vessels by something. Maybe a large lymph node. We have the mess. Aortic, para-aortic lymph nodes. So maybe there's some sort of major infection going on. Lymph nodes become very large, start compressing the vessel. Mass or tumor maybe. So again, with this acute or occlusive disease, again, sonography is not going to be useful. We don't really have time, to do that whole process. Non-obstructive mesenteric arterial insufficiency. So this would be an issue, it's not an obstruction, it's not a stenotic lesion that's causing the ischemia or the insufficiency of blood supply. it might be due to some sort of low blood volume. So maybe they're hemorrhaging or bleeding somewhere internally. So caused by hypotensive shock, blood loss, or sepsis, that leads to that insufficient blood supply to the bowel. So again, this is critical. This is person, they're in shock, they're hemorrhaging, they're bleeding somewhere. It's no time really for us to really be getting involved. Mesenteric ischemia, a lot of people don't think of it. We're just focused really on those arteries, but it could be an issue on the venous side now. So if we have poor venous drainage and we wind up with occlusion or thrombosis in the drainage, so now blood flow is, it's entering in, but it's not draining out, and that leads to some problems. So again, sonography plays a lesser role due to the limited ability to visualize all that venous vasculature drainage. Or it could be a chronic issue. So the chronic is kind of that fourth, vascular cause or fourth cause. Again, with chronic, that's the development of those atherosclerotic plaques over time, narrowing our arterial vessels. So here we said sudden onset of symptoms that can progress to a life-threatening condition. So they present, with severe abdominal pain, they evacuate their bowels, there might be abdominal distension, fever, dehydration. Eventually this could lead to acidosis, and even potentially death. So again, acute mesenteric ischemia is a surgical emergency, and CT is going to be that preferred method of diagnosis. So patients who have chronic mesenteric ischemia, again, this is secondary, like I said, to that atherosclerotic narrowing and or occlusion of the major splanchnic arteries. So their symptoms are a little bit different. So they have pain after eating, that postprandial pain, substantial weight loss. So again, poor perfusion to the intestines. They're not digesting their food properly. They're not getting the nutrients from their food. So they're starting to lose weight, become thin, dehydrated. And then we can potentially hear those abdominal bruits. So when their doctors, auscultating, listening to their abdomen, they can potentially hear those stenotic lesions. So those are the three things that we look for, or signs of a patient who potentially has chronic mesenteric ischemia: that postprandial abdominal pain, pain after eating, substantial weight loss, and then potential abdominal bruit. So on ultrasound, ultrasound can be utilized. CT, MRA, angiography are also used as diagnostic methods. Like I said, you could try with ultrasound. Maybe again, it might be contraindicated. They can't get the contrast for CT. Maybe their kidneys are bad. Maybe they're not an ideal candidate for an MRA. Maybe they have a metallic implant, or defibrillator or something cardiac. So we might be the only, option available to them, so push back, but don't push too hard. With ultrasound, we're going to assess flow resistant patterns in the fasting patient. We look for duplex detection of stenosis or occlusion. Again, we look for the clinically significant diameter reductions of greater than 70%. So that's why that, peak systolic velocity criteria is the one that really, they focus on. Is the greater than 70% diameter reduction. And then the 2-vessel rule, where you have to identify, 2 out of 3 vessels being positive to make that diagnosis. So 2 out of 3 have to be stenotic in order to qualify for or make the diagnosis of chronic mesenteric ischemia.
In the notes, it says substantial weight loss due to fear of food. Like, are they scared to eat it because they're in pain? Like, is it due to like the pain?
On her notes.
Fear of food?
Yeah, I mean, if you're having pain after you eat, to me, substantial weight loss would come from dehydration and like poor absorption of nutrients. Like your gut's not working right, That's what Lily wrote.
Yeah, that's
Those are Lily's notes. I don't look at her notes. Yeah. I wish I could have sat in on one of her lectures, or we overlapped, like You know, I never really got to see how she taught her class. I can only imagine, like, from what I've heard, like, lectures were like 4 hours. Like, it was a marathon. It's like, all right, class is from 9 to the rest of your life. Or the colleges tell me I gotta give you 30-minute breaks. Like, every 30 minutes, I gotta take a break. So again, utilize your color, look for aliasing, luminal narrowing, turbulent flow. You get a Doppler, you know, make sure you have proper Doppler angles. Looking for, you know, that increased flow velocities, post-hoc turbulence. So keys to a successful examination or adequate patient preparation. Having good ultrasound equipment, so this isn't something you want to tackle with a little portable machine. You want a, you know, good machine. You need some experience, you know, be able to, you know, locate and find the vessels and know your diagnostic criteria. Correlation with confirmatory studies, so you can compare it to a CT or an MRA if they have that. Grayscale evaluation, should you be able to see those atherosclerotic lesions, those calcified plaques. You could potentially see thrombosis or thrombus within the vessels as well. Reversal of flow potentially, you know, due to some collateral flow and presence of those calibraries. Again, ideally, you don't want the patient fasting for a long period of time. So, like I said, overnight is going to be best. So, a good long 12 to 8 hour, 8 to 12 hours. Patient's going to be supine, quiet respiration. You might have to cube them or scan obliquely. So get good grayscale color Doppler images. Utilize a nice small sample gate. Make sure your Doppler angles are correct, because again, velocities are critical now. We're going to use our curved linear probe, so a 2 to 5 megahertz curved linear transducer. So with our examination, we could look at that celiac artery, rule out median arcuate ligament syndrome or that celiac band syndrome. Evaluate again for chronic mesenteric ischemia. We could look to see if we see any potential collateral vessels. Patients do have disease, you know, there are surgical procedures that can be performed, and we can do mesenteric artery bypass grafts. Limitations, you know, this is more technically difficult exams. Looking for plaque, luminal narrowing, potential aneurysm as well. So that's another thing if you think about it also, you know, we have patients who have AAAs. If they have a large abdominal aortic aneurysm, you know, that could definitely impact the inferior mesenteric artery. So particularly if there's that, you know, mural thrombus, you know, thrombus, that IMA might be thrombosed, or, you know, thrombus might fill the IMA. So that, you know, could be an issue. If it's not thrombosed, you know, and there are aneurysmal, you know, the velocities are going to decrease, you know, in that distal portion of the aorta. So IMA could be stenotic, and we could see atherosclerotic plaque in it, but the velocities, you know, don't meet the criteria because that aortic velocities are so low. Evaluate the patency, Doppler waveforms, measure velocity measurements again of our 3 vessels. Move the Doppler cursor slowly from the origin to the visualized segment of the mesenteric arteries to search for the highest stop velocities. Basically, that's telling you just kind of walk through the area of stenosis, taking multiple sample or Doppler measurements. So abdominal aorta at the level of the celiac artery and SMA demonstrates forward flow in systole with some continuous flow, forward flow through diastole. So we'd expect that. Have some diastolic flow at this level. So I mentioned, you know, if an aorta is aneurysmal, the velocities are going to slow down. That might impact the velocities that you get. Now, on the flip side of that, if the aorta is very stenotic and there's lots of calcifications within the aorta, and we have elevated velocities in the aorta, those branch vessels might be okay, but they just might have elevated velocities because the aorta is so fast as well, so that could impact it as well. It causes falsely elevated velocities. But chances are, if the aorta is atherosclerotic, those vessels are also going to be atherosclerotic as well. So it just might not be as severe as what we're seeing. This was a large, again, AAA. Fuck his bladder. That's a little big bladder.
I think they're fine. Getting bladder. No, that's just good. I just,
So again, within that aorta, there were very low velocities, visualized in that abdominal aorta because it's so aneurysmal. So in addition to the celiac artery, you should also evaluate the splenic artery and the common hepatic artery. You could potentially note the direction flow in that common hepatic artery and the gastroduodenal artery. Evaluate the patency, of those veins as well. So in lab, I'm gonna have you look at SMV, superior mesenteric vein, splenic vein. We already did, I'm sorry, we'll look at SMV. We already did splenic and portal. So you guys know how to look at those and assess those. So we'll add SMV now for our next comp. Yeah, we're just looking again for thrombosis, make sure that there's good drainage, of those vessels. Also examine liver, gallbladder, pancreas, spleen, kidneys. So you're taking a quick look at these things, making sure there's no evidence, of infarct, of those hypoechoic wedge-shaped lesions in any of these organs. Not so much gallbladder, but definitely liver, pancreas, spleen. Look for any enlarged lymph nodes around the aorta as well, because again, those could potentially compress the vessels. If it's a follow-up exam, look at that follow-up exam and try and utilize similar Doppler angles or similar Doppler angles to try and, get your velocities to correlate and match up. So this was just kind of a general protocol that we found, talking about preparation, the images and the vessels. So it starts with, in the aorta, sag aorta, around the level of the celiac SMA. So, right at the, I guess the distal end of the proximal aorta. So that's going to kind of be like your baseline velocity, and then you can utilize that to compare to our other vessels as well. In the celiac artery, patency, look for those elevated velocities. Celiac, we'd also assess splenic artery, common hepatic artery, measuring peak systolic and diastolic velocities. Look to SMA. Typically, you do 2 segments of the SMA proximal near the origin, then try and move a little more distal, get mid SMA, and then evaluate IMA. And then you can look at the venous drainage as well. So SMV, splenic vein.
Yeah, and would the SMV be like the way we take sag pancreas?
Yes. Or sag pancreas. And just remember your velocity criteria is 200, 275, 200. Easy peasy.
Sit up straight.
Let's stop shopping.
Yeah, there you go.
Oh gosh.
I guess that's true.
Wasting girls for your stews. All your faces. Yeah, so come in, so we're just kind of finishing up lecture, so this is Riverside, this is our home. We actually had some construction this morning, it was super duper loud. And like, I was like, you guys wanna chase concert, but no, this is our home. So yeah, this is our, basically our lecture classroom, where we have our lectures.
We'll hang out back
Yeah,
there.
sure. Yeah, I'm actually like, well, pretty much almost done. Pitfalls. So again, just be cognizant of anatomical variants, you know, because they do exist. That's when things get a little interesting and can be a little bit tricky. Low resistant hepatic artery waveforms could be misinterpreted as increased diastolic flow associated with SMA stenosis. So again, now, just again, think about it. You know, when we have stenotic lesions, the body's trying to compensate now. So it's trying to bring extra blood flow to places where it needs it. So, you know, if my IMA or SMA are blocked or occluded or stenotic, that SMA, the flow is going to increase because it's trying to supply those territories now and act as the sole blood supply. So velocities will go up. So, you know, we might misinterpret that as being now stenotic, but it's good, it's normal, there's no stenosis, just increased flow. So that could happen, you know, with any of our branch vessels. Be mindful of median arcuate ligament syndrome. So we'll see in a moment if anyone here has it. Maybe, possibly. Tends to be more prevalent in females. I haven't seen it in a guy yet, but like the last couple classes, we've had at least one person with it. Low flow velocities in the mesenteric arteries may be due to aortic aneurysms. We talked about that. We know the velocity slow down when you get into that into the abdominal aorta. That could skew your measurements as well. Cardiac arrhythmias, we have variable velocities. So when you get that, try and pick one in the middle. So typically with the arrhythmia, you have one very fast, and then one very low, and then one kind of in the middle. Presence of severe stenotic disease within the aorta can also increase those mesenteric velocities. Younger patients, so with strong cardiac output, they have a nice young heart, they naturally will have faster velocities just because that heart is stronger. And then again, careful history, ensuring that patient is truly fasting to avoid misinterpretation. There are bypass grafts and stents that can be placed in these vessels. So we can do an angioplasty, do a balloon angioplasty, try and open up those vessels. We've done that work to open it up now with the balloon angioplasty. They can place a stent in there. So they might be coming in for a follow-up to view that stent, make sure it's not becoming re-stenosed, making sure that there's now adequate reperfusion of that vessel as it's opened up. So with angioplasty, 20 to 40% patients after angioplasty develop neo-intimal hyperplasia. You guys remember that? Neo-intimal hyperplasia? Where do we see it?
After.
In carotids? What's the name of the surgery?
Endarterectomy.
Endarterectomy, yeah. So status post endarterectomy for the carotid arteries in the neck. Yeah, that's the body's kind of natural response to trauma. The walls become hyperplastic or thickened. They start to grow and then recreate stenosis. So it's referred to as neo-intimal hyperplasia. If there are grafts, you know, present, so you know maybe they created a graft and they're tapping in maybe into the aorta, trying to bypass the stenotic area and then get into SMA or IMA further distals, because we said those stenotic lesions are near the origin. Maybe they could do a little bypass graft, get around that stenotic area, tap back into the SMA to kind of reperfuse it. If that's the case, you would have to image that graft in its entirety looking for those two anastomosis sites. Diagnostic criteria, so if there is a graft or stent that there's placed, the velocities are a little bit higher now, so we look for greater than 300 centimeters per second to qualify as stenotic when there's a graft or stent placed. Nice thing about a vascular lab, when you go to do this, if you're working in a vascular lab, they'll have nice little charts on their walls with all their velocity criterias. So, it'll help you as a new student, so don't worry, stress too much about it. But definitely for boards, 200, 275, 200. Clearly visualized. Then occlusion. What's the rule of occlusion? What do we have to do to make that diagnosis of occlusion? What do I tell you? You have to do
Power.
power Doppler. Good. Always put your power Doppler on there. If it's truly occlusive with power Doppler, no color flow, no Doppler signal. Even with power Doppler on, you might not see flow, and you put your pulse wave. Oh, look at that! There's a little tracing in there. Optimize, raise your gain settings, so your pulse wave Doppler gain, crank it up until you get that snow, and then just turn it down a little bit, and then just you prove it's occluded. Because again, that dictates what they can do. If it's occluded, you're poop out of luck. Poop out of luck. Nice way to put it. But if there's a little bit of flow, they can get a catheter in there, they could stent it open, balloon angioplasty, and you could, potentially save that vessel. That's it. Short, sweet. Isn't it so much better third semester?
This is much better. What?
What? I know.
What?
I know.
It was supposed to be combined with last week, but I just. Let it. That's okay.
I like that. I actually forgot.
I see to have one thing.
We're going.